Shall we start, sir?
Yeah.
Good morning, all. Welcome you all to the special webinar series being organized or conducted exclusively by the Residents Committee of KCIAPM. So, these are the sessions which have been planned, executed, and conducted by the residents themselves. Half of the Residents Committee today is Dr. Supriya Nandi, who is a second year postgraduate student from JJ Medical College, Davangere, and she will be conducting the session. And as a faculty for this particular session on cracking the clot code and demystifying the coagulation disorders, we have the immediate past president of KCIAPM, Dr. Suresh Hanagwadi sir, who will be delivering this talk. And he needs no introduction, but I invite Dr. Supriya Nandi to have an official introduction of Dr. Suresh Hanagwadi before we begin the live session. So over to you, Dr. Supriya.
Thank you,
Thanks.
sir. Good morning, everyone. Myself, Dr. Supriya, member of Residents Committee, KCIAPM. I'm your moderator for today's session, whose speaker is very well known for his services and care. It's a tremendous honor to introduce one of the most distinguished personalities in pathology, Dr. Suresh Hanagwadi, sir, currently serving as a professor of pathology at JJ Medical College, Davangere. Dr. Hanagwadi, sir, brings over 3 decades of expertise in pathology and hematology. A trailblazer in his field, he has significantly contributed to blood disorders, management, blood safety, and hemophilia care. Dr. Hanagwadi sir is the founder of the Karnataka Hemophilia Care and Hematology Research Center, which has been providing diagnosis, treatment, and rehabilitation services at over 20 years. Dr. Hanagwadi sir's academic journey is as illustrious as his professional one. He has participated in multiple international congresses of the World Federation of Hemophilia across the globe, from the Canada to Australia, and has represented India in various global advocacy initiatives. His affiliations are numerous, some of them which I can name. Sir is the founder and president, Karnataka Hemophilia Society, Davangere, and involved in developing hemophilia care services. He is advisory council member, Karnataka State Commissioner, Department of Persons with Disabilities. Sir was former president, Hemophilia Federation, New Delhi. He is the member of World Federation of Hemophilia, Montreal, Canada. The life member, Indian Medical Association, Indian Red Cross Society, Karnataka State Branch, India. Former member, Medical Advisory Board, Hemophilia Federation, and Vice President for Karnataka chapter of Indian Association of Pathologists and Microbiologists. There is still a lot to say. His contributions include groundbreaking research, publications, and educational programs that have revolutionized hematology and to be specific on hemophilia. In India, more than 10 webinars on hemophilia were given in the last 2 years. Beyond academia, he has been a pillar in the Hemophilia Federation, spearheading initiatives that led to the inclusion of hemophilia care under the Disability Act in Karnataka. His commitment has earned him prestigious honors such as he received the prestigious National Shrestha Divyangjan Award 2024 from the Honorable President of India, Amrita Mahotsav Karnataka State Rajotsava Award 2021, National Award 10 Outstanding Young Indians 2001, the Red and White Bravery Award, the Karnataka Rajotsava Award, the Karma Veera Chakra 2011, Seva Sangama Award, Karl Landsteiner Memorial RBC Award, Matrubhumi Seva Award in 2017, NS Hima Memorial Award, World Federation Hemophilia International Award, Treatment Center, Twinning Program with Hemophilia and Thrombosis Treatment Center, Alderhead Children Hospital. Today, we are privileged to hear him simplify one of the most intricate topics in medicine, the coagulation cascade. Dr. Hanagwadi sir's ability to transform complex topics into memorable practical knowledge is unparalleled. I urge all of you to share this session with your friends and colleagues so they too can benefit from this exceptional learning opportunity. Let's expand our audience and learn together in larger numbers. Before we dive into this session, a quick announcement for everyone. The much awaited CAPCON 2025 will be hosted at Bangalore Medical College this July, promising an exceptional lineup of renowned speakers and interactive sessions. Don't miss the chance to register and be a part of this enriching academic journey. Without further ado, let's welcome Dr. Suresh Anagwadi sir as he takes up through the fascinating world of coagulation cascade. Over to you, sir.
Thank you, Dr. Supriya. for your nice introduction. Yes, today we are dealing with uh, demystifying the clotting disorders. At the outset, I would like to thank our KCIAPM President Dr. Vijay Shankar and Dr. Aditya, who is always with innovative and technology advancements. And it is my privilege to utilize this platform to address the student community, residents uh, committee. I would like to thank Dr. Nitya Shri also for this arrangement. Today, I am trying to make it a simple approach to the diagnosis of various bleeding disorders. And all of you are aware that normal hemostasis depends upon the four important pillars: our vasculature, our platelets, our coagulation system. As once the bleeding stopped, the debris, it needs to be cleared. That is, for that fibrinolytic pathway helps us. So overall, these four important pillars are the main crucial in maintaining the blood in fluid status. And if any pathology, any one of these component, that leads to the bleeding disorder or even thrombotic disorders because of fibrinolytic pathway. So this, I will not go into the detail. Already you are well aware about normal hemostasis, the different pathway, extrinsic pathway, common pathway, uh, intrinsic pathway. These are the traditional coagulation pathways we have learned over decades. But nowadays, there is slight change. The recent concept in the coagulation model, we uh, we have slightly changed. That is initiation, amplification. So mainly nothing much change, but that the crucial role of thrombin is emphasized in this pathway. So with this, so what are these bleeding disorders? Pathology of the bleeding disorders. These occurs due to any defect, as I told you, maybe in the primary hemostasis or secondary hemostasis or sometimes both, and their diagnosis based mainly on clinical evaluation of the patient, which we will see later, and basic hematological investigations. Of course, we need some special investigation or confirmatory test to come to the conclusion of the diagnosis. And specific diagnosis of bleeding disorder is very crucial because because the treatment depends upon the particular bleeding disorder, especially the replacement therapy. If it is factor 8, you have to give factor. If it is factor 9, you have to give factor 9. So that's why the laboratory diagnosis is crucial for treatment also. So diagnosis, treatment of bleeding disorder needs even because these are the lifelong disorders, incurable disorder, genetic disorders, and we need to focus also on education, counseling, rehabilitation of these patients as well as their family members. And as I told you, these are all genetic disorder. We should also give emphasis on prevention of the birth of these expensive children. Otherwise, it will incur heavy healthcare burden in the country. Now, coming to how to approach, how to demystify these disorders. The bleeding, as I told you, history taking is very, very important. Of course, you should observe, examine the patient with certain skills, and later a battery of laboratory investigations required for the further evaluation. As I told you, history taking is very important, and 80% of correct diagnosis can be made by history taking and physical examination. See, I will quote certain points here. The age of onset of the bleeding, will tell you whether it is inherited bleeding disorder or acquired bleeding disorder. Inherited bleeding disorder manifests early, from birth to even childhood age, whereas the acquired bleeding disorder occur later part of the life. And the type of bleeding also matters. The superficial, whether it is a superficial bleeding, whether it is a mucocutaneous bleeding, or whether it is a deep-seated bleeding, whether there is a muscle hematoma into the joint. So this also helps in differentiating the the platelet disorder, vascular disorder from the coagulation disorder. And even the typical bleeding is very characteristic in coagulation disorder. See here, it is slow, prolonged, sustained bleeding. Whereas the primary hemostasis bleeding is a profuse bleeding, free flow of blood. Even in DSC, they bleed from the injection site. Whereas the coagulation disorder, they don't gush their blood. They bleed is very typical, slow, prolonged, sustained. Why? Because their primary hemostasis is absolutely normal. They can produce primary hemostatic plug, but unfortunately, the strengthening of this platelet plug is affected. That is no the defect in the secondary hemostasis. So that's why patient feels bleeding is stopped, but after some time again he will rebleed. Slow, prolonged, sustained bleeding is very important of coagulation disorder. Okay, then birth history. Okay, birth history, especially the most of the, for example, hemophilia, they don't manifest 6 months or even up to 1 year. Whereas there are certain coagulation disorder manifest during birth. Okay, in the form of umbilical stump bleeding, prolonged umbilical stump bleeding, or delayed wound healing. So all these typical feature of congenital coagulation disorder, either fibrinogen deficiency or the factor 13 deficiency. Okay, you note down the past history. Okay, once while taking history, you document whether there were similar bleeding episodes in the past, and more important, how it was treated. How it was treated, whether any patient received blood, whether this patient received any concentrates or cryo, FFP, that will give a clue. This should be a hereditary bleeding disorder if there is a previous bleeding episode and which were treated by replacement therapy. Then post surgery bleed. So this is very common in our hospital setup, which I will emphasize later, especially in the Muslim community, ritual circumcision, or any the patient who undergo tooth extraction and bleeding doesn't stop. So that's why the post-surgery bleed, post-circumcision bleed is also should be noted down. As I told you, treatment history, transfusion or replacement therapy. Yeah, another very important is you should take whether patient is on any drugs, especially aspirin. Why? Aspirin interfere with the platelet function. Aspirin interferes with the platelet function. It can give erroneous laboratory investigation, even including prolonged clotting, prolonged bleeding time. So that's why the drug history, especially aspirin, anticoagulation, should be documented. Okay, and menstrual history in female, the menstrual history, especially the puberty menorrhagia, the menstrual cycle details should be taken. But nowadays, we insist for a standardized questionnaire by put forward by ISTH. We call the bleeding assessment tool. Bleeding assessment tool. So these are the parameters which you can download from the Google, and you keep it in while taking the history, and take these history nearly around 14 parameters, maybe from epistaxis or cutaneous bleed or minor wounds, oral cavity, gastrointestinal bleed. Okay, so these are the parameters, and each parameter you can grade from 0 to 4 based on the severity. So score more than 3.5 indicates patient has got significant bleeding episode or bleeding tendency which needs to be evaluated further. So family history is always important, because as I told you, these are genetic disorder, and better to write a family pedigree. Why you need to write family pedigree? To ascertain the mode of inheritance. You note down whether they are consanguineously married or not, because most of the genetic diseases are more common among consanguineously married couple. And is there any deaths or abortions in the family? So this is very important. So series of pregnancy loss, series of abortions is a characteristic feature of factor 13 or fibrinogen deficiency. If this history is there, you please note down. So family history. Now we'll come to the physical examination. Now look at the patient, look at the lesions, how they are. Okay, as I told you, superficial mucocutaneous bleed is a characteristic feature of primary hemostatic disorder. So these are the lesions, petechial hemorrhages. Petechial hemorrhages, very small, pinhead size within 2 millimeter. Purpuric lesions more than this, within 1 centimeter, and little deeper involving the subcutaneous tissue, and they can we call ecchymosis. And these, yeah, now these are the petechial hemorrhages 1 to 2 millimeter. So the purpura and ecchymosis, little deeper structures are involved, but not any cavity or muscle. Okay, so yeah, the next one, the secondary hemostasis. Okay, secondary hemostasis, as I told you, characteristically the bleed is slow, prolonged, and sustained bleeding. So blood trickles is the ideal term we can tell. Blood trickles in hemophilia or any coagulation disorder, because of primary hemostasis is normal, and only the problem is a reinforcement of that primary hemostatic blood, which doesn't occur because of the lack of certain clotting proteins. And they bleed internally in the joint, in the muscle, in the even any part of the body, any internal, especially the life-threatening bleed like brain hemorrhage can occur. Now, with this clinical history and physical examination, now let us plan the laboratory investigation. So, laboratory investigations are aimed at to know or establish the diagnosis resulted the like vascular disorder or platelet disorder or coagulation disorder or any inhibitors and even fibrinolytic. So that's a bleeding disorder present differently depending upon causative problem. So platelet disorder, as I have already mentioned, so they bleed mucocutaneous, mucous membrane, okay, epistaxis, gum bleeding. So these are more common with the primary hemostatic plug, whereas patients with coagulation defect, deep-seated bleed. Okay, now you plan investigations. How to plan investigation of suspected bleeding disorder? Yes, this is common everywhere it is available, complete hemogram or CBC, with more emphasis on the platelet count and good peripheral smear examination, and yes, modified IV's bleeding time. Modified IV's bleeding time or platelet function analyzer. So in Western, the bleeding time is replaced by platelet function analyzer. But anyhow, in our country, we resource restricted country, still we need to do bleeding time, but don't do all those crude method, the capillary breaking and all just pricking. So no, it has to be done by a standardized method, which you will see later. So that is called modified IV's bleeding time. And plasma clotting test. Plasma clotting test, each pathway can be determined. The prothrombin time will tell you the integrity of the extrinsic pathway. APTT will tell you the integrity of the intrinsic pathway. Thrombin time, common pathway, or even all the pathway, including intrinsic pathway. Okay. Then after knowing if there is any prolongation of these plasma clotting tests, then we need to plan for mixing studies. Mixing studies, which we will say, will elaborate later. And once you do mixing studies and pinpoint the particular factor deficiency, now we need to do specific factor assay to determine the severity of the bleeding disorder. For example, factor 8 or 9, what is their level, whether it is severe, whether it is moderate, whether it is mild category. Then say for fibrin degradation product is evidence of fibrinolysis. Okay, now we'll have little more discussion on this. The platelet count nowadays, manual as well as the Coulter counter, and bleeding time modified IVs method. And now, caution note I would like to add here is bleeding time, clotting time, still they are not most sensitive tests. Okay, most sensitive test, especially the clotting time is absolutely useless test. That's why we always tell that these are not sensitive tests. If they are prolonged, you accept it. But if they are if they are normal, the mild bleeding disorder cannot be ruled out. For example, mild hemophilia will give normal clotting time, and believing that if a patient is subjected for surgery on OT table, bleeding doesn't stop. So that's why the clotting time, in fact, it misleads. That's why it is better not to encourage the clotting time as a part of our evaluation. And one more, clot retraction. Clot retraction, all of you know that it is the integrity of the platelets. So that's why let us utilize. But however, it is also not very sensitive. But if it helps, especially in the diagnosis of functional platelet disorder. So that's why one very caution note is the normal clotting time doesn't rule out underlying mild to moderate clotting factor deficiency. So if they are prolonged, as in severe category, you note down and document. If they are normal, be careful. You are not ruling out mild factor deficiency. The modified IV's bleeding time with standardized method. Standardized method means, yes, with under the standardized conditions. Okay, you inflate the cuff and maintain 40 millimeter of mercury throughout the test, and take Lancet, or nowadays even the some templates are available. And with these three successive incisions has to be made, and switch on the stopwatch, and note down the time. So the modified with this method, modified IV's method, the bleeding time generally 2 to 6 minutes. If it is prolonged, and if it is more than 15, stop it and note down it is prolonged. So bleeding time by modified IV's method should be practiced, because you will not miss the disorders. And clot retraction, as I told you, so after the formation of clot, it starts contracting. After about 30 to 45 minutes, a straw colored fluid we call serum is expressed, and the amount of serum expressed will tell you the function of the platelets. So that's why we call it as clot retraction. Most of the laboratory, they ignore this test. But especially functional platelet disorder, if platelet count is absolutely normal, but not even a one drop of serum is expressed, that is more than enough to suspect functional platelet disorder. So these are the contractile proteins, actin, myosin, thrombostatin, are responsible for the clot retraction. And yes, now a peripheral blood smear is a equally a single most important the parameter, which will tell you many things. Okay, you can see, for example, absolutely normal platelet count, prolonged bleeding time, and poor clot retraction. And in the peripheral blood smear, not even a clump. Most of the platelets are, they are all discrete, no clumps. The diagnosis, it is Glanzmann's thrombasthenia. So you can make the diagnosis Glanzmann's thrombasthenia. If patient is affordable, you can do platelet aggregometry and try to establish the diagnosis of Glanzmann's thrombasthenia. The theory part, and know all. Okay. So, but platelet aggregation, again, there are agonists. Okay, ADP, epinephrine, collagen, and ristocetin. See, classically, with these investigations, and if the aggregation doesn't occur in any agonist except ristocetin, almost you are with the diagnosis, that is Glanzmann's thrombasthenia. Glanzmann's thrombasthenia. And also nowadays, flow cytometry facilities are also available, that will CD41 and CD61. or will help you diagnosis. Whereas Bernard-Collier syndrome and Van Willebrand's, you need to differentiate. There also, what we do some correction studies that the plasma, that is APT is prolonged in Van Willebrand's, whereas in Bernard-Collier it is not so. Like this, with these points, you can differentiate Bernard-Collier from Van Willebrand's. So now we'll come to the basic coagulation profile. So how to plan your investigations. Yes. So for every slide, I have included the guidelines of our World Federation of Hemophilia, and these resources can be downloaded from our website www.wfh.org, and all the resources, the guideline book, you can download and refer them. Okay, an accurate diagnosis depends upon laboratory following strict protocol. The coagulation profile needs very strict control, quality control measures. Otherwise, erroneous results are bound to happen. So, expertise in coagulation laboratory testing, you have to train your technician how to prepare the sampling, sample preparation, and even testing, manual or even semi-automated or fully automated. And also focus on your equipment. Regular calibration of equipment is needed, and selection of good reagents is needed. So that's why with this, the diagnosis, especially hemophilia, depends upon typical clinical feature and screening test, isolated prolongation of APTT, and also further the diagnosis by specific factors, say, and other investigations. Okay, that's why what is the recommendation of our WFH? WFH recommends that testing for diagnosis and monitoring of coagulation disorder like hemophilia must be carried out by staff with knowledge and experience in coagulation laboratory testing using equipment, reagents that have been validated for this specific purpose. Okay, so details of laboratory test, yes, as I told you, you can also, there is a, you can go to WFH site, and also we have learning platform also, you can get these things. This is the link you can download and approach. So now we'll come to the plasma clotting test, secondary hemostasis function. So as I told you, prothrombin time, extrinsic pathway, activated partial thromboplastin time, intrinsic pathway, and thrombin time. So these are the three. You are opening the window. Okay. Now you see, while collecting the blood sample or while planning the basic coagulation workup, you need to again spend some time on history taking. What are these? You should know whether patient is on aspirin or not. If as patient is on aspirin, don't take further investigation. You defer the investigation and you advise him to come stop aspirin and come after 1 week. Okay, and again, naturally, anticoagulants like heparin and coumadin, warfarin, and if patient has received blood or blood components like FFP, cryo, or even concentrates before the final diagnosis, it is not ideal to do the investigation. But sometimes patient comes with a bleeding episode, you have to stop the bleed. So what to do that time? You can't tell them come after 3 months. Okay, 3 months generally we defer if there is a replacement of blood and blood products. So what you can do during those situations, you can do plasma clotting test, you can do mixing studies. Only factor assays may not be reliable, but definitely you can pinpoint patient's factor deficiency for the treatment purpose. So once that bleeding episode is managed, you advise him to come after 3 months for complete workup. Again, the drug, the anticoagulants. Okay, so now you come to the with history, and that's why we give appointment better on prior appointment. These investigations should be planned. Okay, so now let us come to how to collect the blood sample. How to collect the blood sample? Yes, this is very important. Careful, gentle, and immediate venipuncture is crucial. Why? Because the blood vessel tissue factor, you cannot meddle with the vein. and that will release lot of tissue fluid, and definitely it will affect with the plasma clotting test. Okay, so that's why it should be gentle, it should be immediate puncture of the vein. So the anticoagulant of choice for coagulation disorder, you should be very careful. You see whether it is the most of the time they take 3.8, which is widely available, whereas for coagulation test you need to prefer 3.2% sodium citrate. And also it is very important, equally important, to maintain the proportion of the blood and anticoagulant. Okay, so 1 is to 9 proportion is crucial. If it is not, we generally clinicians will send with a mark, but they collect, say, staff nurse who is not, doesn't know the implication, they will draw the blood sample more or less. That is that, without any hesitation, or we can't do, you have to reject those samples. Test should be done as early as possible, because you are evaluating the proteins. Each protein has got its own half life. Okay, you cannot delay. But anyhow, in general, internationally, so we tell earliest, and not more than 4 hours. Okay, especially factor 8, factor 9 assay, you try to do the investigation within 4 hours of collection. And the sampling is important. How to process the blood sample? Once you collect the anticoagulated citrated blood sample, you do centrifugation. Okay, centrifugation, why we call high spin plasma, low spin plasma. High spin plasma, that is around 2500 to 3000 rpm for 15 minutes, 10 to 15 minutes. That will give you the platelet poor plasma. Platelet poor plasma. Why we want to avoid platelets? Because platelets are rich in phospholipid. So that's why for coagulation test, platelet poor plasma has to be preferred. So that's why sometimes what we do, we follow this two syringe technique. Two syringe technique. First syringe blood is meant for the routine investigations like cell counts and all those. Then the second syringe, by that time the amount of tissue fluid and everything will be very low, and the second syringe blood, citrated blood, will be preferred for coagulation test. So as I told you, the 3.22% sodium citrate, you know, the blue capped anticoagulant vacuum container. Then, yeah, one more thing you need to take while doing coagulation profile. Yes, anyhow, you do CBC, by that time you will come to know the hematocrit. Okay, high hematocrit. You see here, high hematocrit. Why hematocrit affects the anticoagulation with the anticitrate? So that you will not be able to maintain that 1 is to 9 proportion. Okay, if a high hematocrit, you have to adjust the anticoagulant required. If it is severe anemic, watery blood, and you see the again this problem, then you have to adjust the requirement of the anticoagulant. So that's why you can paste this post in your lab. And if the hematocrit, this is a standard, this is a what you call the standard calculation, and you can label 25 to 55, 0.5 to 4.5. Accordingly, if the hematocrit is too low, you have to adjust the anticoagulant. This is very crucial. Otherwise, your test will be erroneous. Okay. Now, as I told you, the centrifugation of the citrated plasma to obtain PPP, platelet poor plasma. Whereas low spin plasma, especially if you are planning for platelet aggregation studies, then you prefer platelet rich plasma, that we call low spin plasma. Whereas high spin plasma or double centrifugation, all these are required to avoid platelets. So separate plasma, then yeah. So test immediately before less stable factor, especially factor 7 has got a shortest of life, just 3 hours. Okay, so do not, if not, keep in the ice bath. Okay, but anyhow, as far as possible, do it as early as possible. Number one, if you want to, then at least 4 hours or 4 hours. Otherwise, if you are not able to do, then you have to snap freeze the sample and keep it in -35 or temperature. Okay, so this is on the specimen will be rejected if it is mislabeled. That all these if it is less or more, then these are all not ideal, because you are wasting important human resource, reagents, and everything. It is better not to continue the test. Okay. Now, what is the recommendation of our blood? Our WFH recommends blood samples for determination of PT and APTT or factors A collected in citrate tubes, the proportion. So whatever I've told, no. So the at least analyzed 8 hours of collection in general, but anyhow as early as possible. Okay, this I think I have already briefed. Okay, now we'll come to each test. Prothrombin time, the tissue thromboplastin time. Okay, and very simple. All of you must have done this. Some anticoagulation monitoring, and also in coagulation disorder, the isolated prolongation of PT can suggest the patient may be having factor 7 deficiency. But however, the most common chronic liver disease, cirrhosis, and vitamin K deficiency, okay, vitamin K dependent factors, all these things you need to rule out before thinking of rare congenital deficiency of factor 7. So the all of you are aware that the data we call prothrombin ratio, patient time and control time. Then INR with that ISA value. Each reagent is calibrated and ensured with the ISA value, and using that you ideally a good screening test reagent should be very sensitive, so that all levels of low factors can be picked up when PT is done. Okay, and at least close to 1 you should prefer. Okay, ISI validated value, that is assigned, indicating sensitivity of the reagent, and most sensitive reagent has ISI close to the value of 1. You prefer for this. Less sensitive reagent will be more than 1.4 onwards, and this international normalized ratio is normalizing the PT express as PR by incorporating the allocated ISA value. Okay, so this is one. But anyhow, in diagnosis of coagulation disorder, we don't. But monitoring of the anticoagulation, that is very, very important. Then the next test, APTT. In APTT, what is the thing? You add activator, clot activator. It may be kaolin, it may be allergic acid, or so many are there. So you prefer, you add activate the coagulation or contact system and do the test. The time taken by citrated plasma to clot presence of negatively charged phospholipid, negatively charged contact activator like silica, kaolin or allergic acid, and calcium chloride. And contact activation will activate the intrinsic pathway by activating factor 12 onwards with the help of phospholipids. So this appropriate amount of calcium needs to be added, that calcium chloride, calcium, so added to for during the test to get it. Thrombin time is used to diagnose bleeding disorders and to assess the effectiveness of the fibrinolytic therapy. The time between the addition of thrombin and clot formation is recorded as the thrombin clotting time, normally 10 to 15 seconds. If reptilage is used, reptilage time should be between 15 to 20 seconds. Thrombin time can be prolonged by heparin, FDPs, fibrinogen deficiency, or the fibrinogen abnormality. So generally, most of the time we use PT and APTT, and thrombin. If both are prolonged, then you have to do thrombin time. If it is isolated prolongation, Sometimes some laboratory, they don't go further with the thrombin time. Now let us see how to interpret. Okay, now you see what are the scenario. The APTT, PT, here only APTT is prolonged. That means isolated prolongation of APTT suspects the defect in the intrinsic pathway. Okay. Whereas here you can see both plasma clotting tests are prolonged, and especially if they are markedly prolonged, then we suspect the common pathway or multiple pathways. Well, in the same way, the isolated prolongation of PT, yes, with normal APTT, so then you have to suspect the pathway, that is extrinsic pathway, very rarely factor 7 deficiency. Otherwise, the most common chronic liver disease, vitamin K, and all those things, you have to think first. Then, if once you rule out, then you can think of congenital factor 7 deficiency. So, guideline says PT and APTT may be used as a screening test in this disorder, and sensitivity of both PT and APTT tests to factor deficiency, yes, are influenced by the type of reagent used to perform the test. Again, selection of the test should be careful. So now WFH recommends for laboratory investigation of patients being assessed due to clinical suspicion of especially hemophilia, the WFH recommends APTT result within the reference range not to be used to rule out the presence of mild hemophilia or hemophilia B. So most of the laboratories we have seen, they try to correlate the obtained value with a bracket reference. That should never be done. You have to run your own control and correlate with the control, normal control. Okay, compare with the normal control and interpret whether it is prolonged or normal. So now coming to correction studies. Correction studies mix with the normal plasma. It is nothing but, yes, now you can see the patient plasma and the normal control plasma. Okay, if it is not corrected, the clotting times remain the prolonged, not corrected, then we have to suspect not factor deficiency, some inhibitors, maybe natural occurring inhibitors or even any allo antibodies. So they can interfere and give prolongation. And typically, if inhibitors are there, the correction will not occur. This point you need to remember. Okay, whereas here you can see patient plasma which doesn't have particular factor deficiency, normal plasma, yeah, they have that particular clotting protein. And if yeah, on mixing, repeat APTT, and if the APTT is corrected at least by 50%, then you say it is a good correction and think clotting factor deficiency. So the message here is the whatever the plasma clotting test prolonged, do with a correction with normal control plasma. If it gets corrected, you are dealing with the factor deficiency. Suppose if it is not corrected, you are definitely, it is not plasma factor deficiency. It has to be inhibitors, especially the lupus anticoagulant is the common in our clinical practice. Then the correction studies, we have used some of the techniques like patient the plasma, that is pooled plasma. So most of the time what we do, we draw a sample of one normal individual and try it, but that should be discouraged. Okay, you have to how to prepare the uh, pooled plasma, normal pooled plasma. You select 20 healthy individuals and collect their sample, citrated sample, pool it, centrifuge, and prepare platelet poor plasma. So that is your control normal plasma. Okay. So the patient poor plasma and normal control plasma. So you can use in the laboratory. Okay. So that is correction, no correction. That is the thing you will get. So whereas there are certain special reagent you can prepare in the laboratory. Okay, so what is our intention? again to narrow down to the cause of the factor deficiency. We call adsorbed plasma. Adsorbed plasma means what? We adsorb certain factors and some factors are left. So the usually easily available, either you use aluminum hydroxide gel and you take around 1 ml of normal control plasma, add aluminum hydroxide or just a pinch of barium sulfate, and you vigorously mix it and centrifuge. And whatever the supernatant you get is your adsorbed plasma. Okay, adsorbed plasma can be prepared by with the adsorption with barium sulfate, aluminum hydroxide. Okay, so again, before taking for the test, you should ensure whether it is well adsorbed or not. How to test this? Again, do PT. PT should be more than between 1 to 3 minutes. 1 to 3 minutes. Okay, then only you can ensure that it is well adsorbed and you can use it for further testing. Okay, there is one more special reagent we need to prepare, as the name itself suggests, aged serum or aged plasma. What is the logic behind this? Yes, you keep the normal control plasma. You know, all these proteins are some are labile proteins, and labile proteins mainly factor 8 is labile protein, whereas factor 9 is a stable protein. So that's why what we want, we prepare aged plasma, either 24, 48 hour incubated plasma, okay, plasma, so that we are sure that there is no factor 8, only factor 9 is left because it is stable. Now use it for further investigation. Okay, so normal control plasma and patient platelet poor plasma is there, and adsorbed plasma and aged plasma or aged serum you prepare. Now you see, but anyhow, you can see here the adsorbed plasma factors present are 1, 5, 8, 11 and 12. Okay, so whereas factors absent 2, 7, 9, 10. Okay, in the same way, aged plasma actually factors absent, especially because hemophilia is most common, no? So the now easily you can say, if the APTT prolonged corrected by normal control plasma and further corrected by adsorbed plasma, then it has to be factor 8. Okay, suppose if it is not corrected, go further, aged plasma you do and it is corrected, then it has to be factor 9. These are the most common, that's why I am telling. So but anyhow, you can diagnose the rare factor deficiency also. For example, you can see, you know already, factor 8 APTT is prolonged, corrected by normal control plasma, corrected by adsorbed plasma, but not aged plasma. The diagnosis would be factor 8 deficiency. In the same way, here you can see isolated prolongation of APTT corrected by normal control plasma, and it is not corrected by adsorbed plasma but corrected by aged plasma. The diagnosis is factor 9. Okay, so when expensive reagents were there, deficient plasma, earlier when we started working, so we used to do these tests only. Okay, but now you see very logically. Okay, so factor 11 deficiency, factor uh, 12 deficiency should be thought. Okay, so here it is isolated prolongation, whereas here APTT is prolonged and it is corrected by both normal control plasma as well as aged plasma as well as adsorbed plasma. What do you mean by that? Neither factor 9, factor 8, and it has to be factor 11 and factor 12. Then how to differentiate these? Very simple logic. The factor 11 patients, they bleed mild. Okay, whereas factor 12 deficiency, they never bleed, they are asymptomatic. Okay, so with these investigation, take a history. If there is no bleeding manifestation, you make factor 12. If there is bleeding manifestation, you can make factor 11 deficiency, which we also call it as hemophilia C. Okay, so now you see here, is there no correction? So APTT is prolonged, but no correction at all. When there is no correction, including the normal control plasma, it is not plasma factor deficiency. Then you have to think of inhibitors. Okay. So in the same way, the other rare factor deficiency also you can do using PT and APTT. Okay. PT factor 2, factor 5, factor 7, factor 10, all these you can do. Only the preparation of the reagent is little cumbersome, but if you have a patience, and also cost, it is cost effective, so it is, you can do these mixing studies and diagnose rare factor deficiencies. Now coming to specific factor assay. What is factor assay? It is nothing but mixing study only. Okay, what you need to do here is serially dilute a plasma, see how much will it reduce the prolonged time, maybe PT or APTT. That's why PT based factor assay, APTT based factor assay are also there. So of a known factor deficient plasma for which assay is done. So for example, abnormal APTT of factor 8 deficient plasma, for factor 8 assay, since all other factors will be normal in factor 8 deficient plasma only, and factor 8 from the test plasma will correct with the correct, that will indicate the amount of factor, that the extent of the correction we need to learn. That's why, as I told you, APTT based assay, that is 12, 11, 9, 8, okay, or the APTT based assay, whereas PT based assay, especially the factor 7 comes under this category. Okay, now you see little bit, and I will mention here, unless to understand or to get the skill, no, better you attend a wet workshop, hands-on training, okay, which we conduct periodically, and if anybody interested, otherwise without these it is difficult. But anyhow, I am trying to simplify these investigations. Dilute standard with known factor 8 approximately 100%, and test plasma in a buffer. Generally we use barbitone buffer or imidazole buffer. There are so many buffer to maintain the pH. So then you prepare 1 in 10 dilution and 1 in 20 dilution and 1 in 40, mixed with equal volume of severely deficient plasma 8 or 9, and do APTT, and you plot standard graph with the correction timings of the standard. On the same graph, plot patient's timing also. So at least 3 points with a straight line parallel to the standard graph is needed. So here you can see serial dilution. Okay, do APTT, and this is the graph that is APT, that is diluted test plasma and diluted standard plasma or normal control plasma. So you can draw the perpendicular line, and you will find the then x axis you will have the percentage of the factor, whereas the plasma clotting value you can plot in the y axis. Okay, this is the typical graph we generally see here. You can see, so for each value, so 1 in 5, okay, 1 in 10, 1 in 20. Okay, so then you test plasma wherever it intercepts, you draw perpendicular line, and you will obtain the deficient plasma level. So that's why with this method, why do we need to do factor assay? Because we need to categorize patients depending upon their level. Severe patients, severe less than 1%, absolutely no factor, and they bleed spontaneously even without trauma, and they bleed recurrent or repeated bleed. And whereas moderate category, 1% to 5%, more than 1%, but within 5%. So these patients, the spontaneous bleeds are uncommon, but they definitely bleed on trauma. Whereas mild category, the dangerous category, so these patients may have factor level between 5% to 50%, or 5% to 25-30%. We call mild category. And why I told dangerous, these patients may not experience any bleeding episodes in a routine daily life, but when they are subjected to major challenges like road traffic accidents, or any surgery, bleeding doesn't stop. Okay, that's why even the clotting time also will be normal. You will be surgeon will be misled. Okay, that's why the guideline, the PT APTT screening test and sensitivity of PT and APTT test to factor deficiency, they are influenced. That's why our guideline is APTT result within the reference range, not to be used to rule out the factor deficiency. Okay, so as I told you, if there is no correction as the lupus anticoagulant or factor 8 inhibitors, okay, there are, whereas lupus anticoagulant is a auto antibody, whereas factor 8 antibody that occurs because of the repeated exposure to the factor concentrate, and they are allo antibodies, and they also come in the way of APTT correction, but characteristically they all time dependent antibodies. Okay, lupus anticoagulant is immediate acting antibody, whereas the allo antibodies produced as a result of exposure to treatment, they are allo antibody, and they take time 2 hours. Okay, after 2 hours APTT will never get corrected. Okay, now you can see here, you can do inhibitor because patients with hemophilia needs periodical testing for inhibitor screening because they are exposed to factors. Okay, so that's why, as I told you, immediate acting, time dependent. What you need to do, you take around 4 plastic tubes and label them A, B, C. A, B, C. Okay, A is patient sample, B is normal control plasma, and you mix it A plus B, that is your C tube, that is your C tube. And one tube, one more tube, label it as D and wait for 2 hours. You keep all these 3 tubes in the incubator and or water bath and repeat APTT of all the samples. Okay, and at the end of the 2 hours, the D tube, you mix it and do APTT. Now you see the normal control plasma, yes, normal control plasma, and APTT result, it is normal here, and not. So that means interpretation normal. Okay, factor deficiency, yes, here normal control normal, and test plasma naturally prolonged. And if you mix it, no, if you mix it and it is corrected, and if you mix it it after even after 2 hours it is corrected, so then you can diagnose only the factor deficiency, whereas here you can see the mixture. So it is test plasma, and the mixture 50-50 mix is also prolonged, and even after 2 hours the APTT mix is not getting corrected, then definitely patient has got immediate the antibodies. So usually factor 8 antibodies are time dependent antibody, whereas factor 9 antibodies are immediate acting antibody. Okay, fact, that is the difference between these two. Most common the factor 8 inhibitor develop, whereas factor 9 is rare, and if they occur it is immediate acting antibody. Okay, so whereas here you can see factor 8, it is prolonged test with 50-50 prolonged, but 50-50 the immediate it is corrected, but corrected, but 2 hour incubated mixture will never get corrected, then you can say the inhibitor. Okay, so further if the test is positive for inhibitor, then further you need to do quantification of the inhibitors. Quantification again is a test we call Nisman Bethesda assay. We want to categorize patients whether they are low titer, that is below 5 Bethesda unit, or more, that is more than 5 Bethesda, that is high titer inhibitor. This is very, very crucial to decide the treatment uh, to control the bleed. Okay, those patients, because what are these inhibitors? Inhibitors are nothing but antibodies against the factor 8 they receive, and factor become ineffective. Okay, life saving drug become ineffective. Then if it is within 5 Bethesda, the only you can modify that, you give high dose of factor 8, double the dosage of factor 8, and it will work. Whereas if it is more than 5 Bethesda, any doubling or tripling won't work. Then the treatment has to be by bypassing agents. Okay, so this is again the Nisman method, and here the plasma, the buffered factor 8 and the buffered factor 8, that is the difference. And you, after 2 hours, you incubate and do factor 8 assay. So our understanding is one Bethesda unit neutralizes 50% of the factor 8 activity. So based on this, we can plot the graph and try to know what is the Bethesda. For example, here on x-axis 5 Bethesda unit 1 point. So 1 Bethesda unit neutralizes 50% of the factor 8 activity. Okay, so this Nisman Bethesda, earlier Bethesda say only incubated mix patient and sample, but now Nisman there is a modified, that is the buffered sample, and because you will not miss some that is false positive, and all those things can be reduced. Okay, so in conclusion, the history and physical examination is very important, and the laboratory investigation, plan your investigation with appropriate history taking, especially drugs, and plan screening tests, specific diagnostic test, and the diagnosis is required for specific therapy, especially factor therapy. Okay, so the last, actually every year, April 17th, we observe it as a World Hemophilia Day, because it is the birthday of our founder of World Federation of Hemophilia, who himself was a hemophilic in Montreal, Canada. He started WFH, and now we see lot of development over the world, and that's why we celebrate his birthday as World Hemophilia Day. And every year we will be having a theme, and this year theme is women and girls bleed too. Okay, so treatment work, because we are advocating for treatment for all, but all these years we have intensified our advocacy for patients with hemophilia. But now please be aware, even in the family of hemophilia, the carrier mothers may also bleed. They may not bleed significantly, but the heavy menstrual bleed is known to occur. And especially rural women, they don't share their menstrual cycle. Even with the heavy menstrual bleed, they try to be like that and have severe anemia and its related complications. Okay, and also the Van Willebrand disease is most common uh, uh, condition we encounter among the women, and puberty menorrhagia. Okay, so all girls with puberty menorrhagia, if we screen them, and definitely they have the Van Willebrand's disease. And like that, there are some other rare factor deficiency, like functional platelet disorder, like gland thrombosthenia and all those. Yes, with this, I would like to conclude. If there are any questions, you can ask. As I told you, better you plan for some wet workshop in your medical college. And yeah, this is my JJ Medical College, the proud college, okay, where I am working as professor. And yeah, so this is our hemophilia society, where we have been working for the inherited bleeding disorders. Almost we are providing the diagnosis, treatment, and rehabilitation, and all these services are at free of cost except lab diagnosis, including 3 meals. Everything is free. Any inherited bleeding disorder can walk in and get these services. And also we have blood bank also, for the sake of other inherited bleeding disorder like factor 13, fibrinogen deficiency, or rarest factor deficiencies. Okay, otherwise factor 8, factor 9, we use it for hemophilia, but rare factor deficiency, we have to go for FFP or cryo or platelet concentrate. But again, as a bleeding disorder community organization, we have committed to give all these blood and blood components at free of cost to any inherited bleeding disorder. It is not only for hemophilia. Okay, I would like to take this opportunity to thank my students community. Student community helped me a lot. The backbone, what the vision, our vision of providing hemophilia, establishing hemophilia care services is possible because of my series of the old students, and especially I must thank our JJMC alumni and for their support. And some of them, even now, they are supporting our hemophilia society. With this, again, I thank Dr. Vijay Shankar, Dr. Ushakini Madam, Dr. Aditya, Dr. Tejaswi, and our HOD, Dr. Vardendra Kulkarni, who always encourages and support our activities. Thank you. Thank you very much. I think I am in time.
Thank you, sir, for that very insightful session. Uh, it was so good that I think there are no questions. Most of them commenting on how insightful and how narrative the session was. Thank you, sir. Dr. Supriya, if you have any questions.
Yes, sir. So thank you, sir. On behalf of all of us, I would like to extend my sincere thanks to our Professor Dr. Hanagwadi, sir, for such an insightful and engaging lecture on the topic, sir. Your clarity and depth of knowledge and passion truly inspired us, sir, and thank you for your perspective. Thank you again, sir, for sharing your time and expertise with us, sir. Thank you,
Thank
sir.
you. Thank you all. I'm proud of our students.
Thank you, sir.
For the benefit of the audience, and I would like to tell that the recording will be available on the School of Pathology platform itself after another couple of hours. You may share the link as well with others who would like to watch it again, and it will be available forever on the session platform. Thanks a lot, sir. Thank you, sir, for that.
Thank you, sir.
Okay, Aditya. Thank you. Thank you very much.
Thank you, sir.